Okay, I think we'll get started. We have 50 participants, which is fantastic. Thank you all for joining us. I'm Jag Sundaram. I'm the Associate Division Director of the Pulmonary and Critical Care Medicine Division in the Department of Medicine. We have invited uh, members across all of the departments, including anesthesia, surgery, and other departments and our colleagues as well to participate in this Zoom conference, because we thought that as we surge into more and more ICUs, some of the providers who have been assigned to take care of these patients may not be as familiar with aspects of critical care medicine as some of us doing it all the time. Uh, we took the opportunity of our noon lecture series that we do every Friday to allow for us to do this as an educational opportunity for all of the members of this group of people who are taking care of these patients. I'd like to thank you all for actually participating in the surge and helping us out in this time of need. And so what we have today is Dr. Radbel, one of our uh, faculty members and an instructor of medicine, who's very interested in ARDS, both as a research topic and clinically, will be providing some very basic information on the management of respiratory failure in general and specifically in the COVID population. So Jared, I'll let you take it away.
Okay, thanks for the introduction. Um, so the plan for this hour is going to be two different lectures. For the first 25 minutes or so, I want to give an overview of how we should be managing respiratory failure in these people who come in with COVID-19. The majority of this lecture is directed towards people who are not ICU trained, to give you guys an idea of what you need to do if you're thrust into this situation. Then I'll take 5 minutes for questions, and then we will move on to the second half hour, which is going to go into emerging controversial topics specifically for the treatment of people with COVID-19. Okay. So the objectives of this first lecture are going to be to give a brief overview of these modalities. We're going to try to choose the correct ventilator settings. We're going to go over how we do lung protective ventilation in patients with ARDS, because the majority of patients who are getting intubated with COVID-19 do develop ARDS. And then we're going to go over some treatments for severe ARDS. All right, so very briefly and generally, there's two things that we're trying to do when we're supporting these patients. We try to improve their oxygenation, and we try to provide them ventilation. So oxygenation can be adjusted with either the liter flow of your nasal cannula, FiO2, if you're providing a specified FiO2 with a high flow nasal cannula, 100% if you're using a non-rebreather. And then if you're using either BiPAP or invasive ventilation, you can set the FiO2. If you are using invasive ventilation, you can also set a PEEP. If you're using BiPAP, the bottom number will be PEEP as well. Okay, and we measure how well we're oxygenating with non-invasively with a pulse oximeter, and invasively we can use an ABG to measure their PaO2. You're going to see one buzz term being used throughout this lecture, and that's the PF ratio. What that is the ratio of your arterial oxygen content by your FiO2. Now remember, the FiO2 is a decimal. So if you're using 100% oxygen, that will be 1. If you're using room air, that'll be 0.21. Okay. Ventilation can be adjusted by changing the patient's minute ventilation. And the minute ventilation is made up by the patient's tidal volume and their respiratory rate. And the way that we measure this, the majority of the time in the hospital, is with an ABG measuring your PaCO2. We can also measure this with end-tidal carbon dioxide if that's available to you. All right, so importantly, I want to go over some modes of oxygenation and tell you what they do in terms of ventilation as well. And because we're talking about COVID-19, which is a communicable illness, we're going to talk about the probability that they're going to generate aerosols and expose providers. So the simplest form of oxygenation is a nasal cannula. It provides oxygenation, but not ventilation. And there are some aerosols that are generated with the patient being able to breathe and cough. Second is the Venturi mask, which instead of a cannula is what it sounds like. It's a mask that provides oxygen at a certain liter flow. That can produce a lot of aerosols as well. Now, the non-rebreather mask is 100% FiO2. It's the highest form of oxygenation that we can give before we give the more advanced modalities below. And that does generate some aerosols as well. The high flow nasal cannula will provide oxygenation. It does provide a little bit of ventilation, but I'm not going to include that as significant ventilation for the purposes of this talk. It can generate aerosols, and we're going to go into ways that we can try to minimize that aerosolization. Now, BiPAP provides both oxygenation and ventilation, but also produces a lot of aerosols because there is a lot of leak from a BiPAP mask. And BiPAP has not been shown to be effective in these COVID-19 people. So you'll see BiPAP is pretty much eliminated from our treatment algorithms. Now, invasive ventilation is your mechanical ventilator. It will provide oxygenation and it will provide ventilation. And as you'll see on the bottom right, I put plus or minus on aerosols. Now, the reason I put that is if you have a closed ventilator circuit, ideally you should not be generating any aerosols. However, if that ventilator circuit is disconnected while you're in the room, a lot of aerosols will be generated. Okay, this is a recommendation from the Society of Critical Care Medicine. And as you can see, they're recommending endotracheal intubation be performed by the healthcare worker who's the most experienced with airway management in order to minimize the number of attempts and risk of transmission. So what I want to put across here is if you have somebody who's failing non-invasive means, you want to call anesthesia, you want to get them on board early so they can have all the tools that are available to them to intubate the patient in the most safe manner for the patient, but also for the healthcare provider. This slide is a respiratory failure algorithm, which is from our hospital. This is our hospital's algorithm for how we're treating these people. And as you can see, we start with a nasal cannula and we start at either 1 liters and we can go up to 8 liters per minute to maintain a pulse ox goal of a saturation greater than or equal to 88%. All right, at this time, obviously, we should have goals of care discussion and code status if that has not already been determined. Now, if you're starting to go up on the liter flow and you're getting greater than 8 liters per minute, you're going to want to start a non-rebreather mask. You're also at this point going to want to contact the people who may need to get involved quickly, including anesthesia and including the ICU team. Now, once you institute a high flow nasal cannula, you want to set an FiO2, which will maintain your oxygenation goal. Now, the other thing that you can set besides the FiO2 on a high flow nasal cannula is the liter flow, or the liters per minute. Now, because it's high flow, you can give a lot of liters per minute. Keep in mind, the higher the amount of liters per minute you give will increase the risk of aerosolization. So we are recommending if you do put someone on high flow, you try to limit the liter flow to less than or equal to 30. You also want to try to put these folks in a negative pressure room if available while you're giving them high flow support. Other things that you can try to do is you can actually try to put an oxygen tent around the high flow, around the patient's mouth. And instead of what you would normally do and provide oxygen through that, you can set that up to suction to try to remove some of the aerosols that are being generated. Now, keep in mind, if you have a rapidly increasing FiO2 requirement, or you see the patient's work of breathing is increasing, or your FiO2 is becoming greater than 60% and you're desaturated, you're going to want to call anesthesia to intubate. Again, this is our goal, to intubate these folks earlier than usual to make sure that it's the safest situation for the patient and for the provider. All right, now I showed these x-rays here because these are all x-rays of people who have ARDS, and clearly if you have this degree of lung involvement, non-invasive means are not going to be effective in a lot of people. So the next part of the talk is going to be going over ARDS and how we treat it. So ARDS is short for the acute respiratory distress syndrome. It's defined by the Berlin criteria. There must be an acute onset, which is less than 1 week of worsening respiratory symptoms. You will have bilateral opacities on chest imaging. Now, those opacities should be generated from edema that is from a non-cardiogenic etiology. And you're going to have a PF ratio of less than 300 with a PEEP of greater than 5. So that last definition is usually the last thing that comes along when you already have the patient on mechanical ventilation. The severity of ARDS is defined by this PF ratio. So if you have a PF ratio less than or equal to 300, that's considered mild. If you have moderate, it's less than 200. And if it's severe, you will have a PF ratio of less than 100. Now, one thing I want to specify about the nomenclature here is you will hear us call severe ARDS at later points in this lecture as less than 150. The reason for that is clinical trials that have used certain modalities have defined severe as less than 150 despite the Berlin criteria. Okay, so you make the decision that you have to intubate the patient. The anesthesia attending intubates the patient. Now we have to decide what our ventilator settings are going to be. On the top right of this slide is a visual representation of what our ventilator monitors look like. The things that we have to set first and foremost are the mode. Now, in most scenarios, what you are going to choose is assist control, volume control. That should be your starting mode. And what you're going to set after that is an FiO2, a respiratory rate, a tidal volume, and a PEEP. To make things easy, everybody who gets intubated will initially start on 100% for your FiO2. Now, the things that we're going to have to then decide are our respiratory rate and tidal volume to provide ventilation, and our PEEP to help support oxygenation in addition to our FiO2. Now, you can see those main things are on the bottom of the monitor, and this is where you can set those variables. Now, the idea for providing support for patients with ARDS is to use a lung protective ventilation strategy. That means that we use a low tidal volume, which is defined by 6 cc's per kg of your ideal or predicted body weight. It's important to keep in mind that this body weight is based on the patient's height, not by their actual weight. Now, our goal is to provide an oxygenation with a pulse ox of 88 to 95% non-invasively. And we allow permissive hypercapnia, which means ventilation becomes less important to these people than protecting the lungs. Now, to what extent do you let that happen? You make sure that you try to keep their pH at greater than or equal to 7.2. If the PCO2 is rising to a point where that pH is dropping further, then you have to do something to increase the minute ventilation, which in this case, we would recommend increasing the respiratory rate and not the tidal volume to no more than 35 per minute. Keep in mind, in this situation for patients with ARDS, it is okay to give bicarb as a means to keep the pH normal and allow for permissive hypercapnia. Now, this is a study from 2011, which was the first to demonstrate on a large scale that low tidal volume ventilation improves mortality in patients with ARDS. And what they did is they provided 4 to 8 cc's per kg of ideal body weight with a goal plateau pressure of less than 30. Now forget the plateau pressure for a second, we will come back to that. The important thing to take away from this slide is that this generated an absolute mortality reduction of almost 10%. And this is the best that we have and the most consistent modality that we have for treating patients with ARDS. Now, given that we are, thrust into treating patients with COVID-19 with very few therapeutics that we know make a difference, the one thing that we can do that we know makes a difference for ARDS is to provide them low tidal volume ventilation. All right, this is a chart of the predicted body weight based on height for women. And as you can see, for your average height for women, you should not really have to deliver a tidal volume anywhere greater than 400. Usually it's going to be somewhere between 300 to 400. Let's say you don't have time to calculate the predicted body weight. For a woman, it's probably okay to start at 350 as an average here. For men, usually we're going to fall within the range of 400 to 500. So if you needed to do a quick measurement, you can do 450, put it in, and then you can tailor this later once you're able to actually measure the ideal body weight. All right, now PEEP. The goal of PEEP is to help recruit alveoli which may not be participating in oxygenation. The more PEEP you give someone, potentially you decrease atelectasis in the lung and provide more space in the lung to provide oxygenation. It also prevents the alveoli from constantly collapsing and reopening, which causes more injury. Like oxygenation with FiR2, our goal is going to be to a non-invasive pulse ox of 88 to 95, or a PaO2 of 55 to 80. Now you can see the higher end here is listed as 80, because as we go up higher and we give too much oxygen, there is the potential of harm from that as well. Now normally we start people with a PEEP of 5. For patients that we are going to be ventilating for ARDS, we're going to recommend starting at a PEEP of 10, and even higher potentially based on patients' BMI, which we'll get to a little bit later. All right, now in general, there are low and high PEEP strategies. This is a nice little summary, and you can actually print this out as a card if you look up the ARDS NETS criteria online. And as you can see, it gives you a brief overview of everything that you need to do to give the appropriate therapy to somebody with ARDS while they're on the ventilator. Now you can see there's lower and higher PEEP strategies. Generally, we can choose one or the other. In general, for these people, we're going to end up probably using high PEEP strategies. And this is a good way to quickly look and see, based on what the patient's FiO2 is, what PEEP should I be giving them. Now, this is from our hospital's protocol, for what our upfront ventilator settings are going to be for patients who are intubated with COVID-19. So immediately upon intubation, we are going to do volume control with that tidal volume of 6 cc's per kg of ideal body weight. And we're going to use a respiratory rate of 16 to 24 with an FiO2 of 100%. Now, the PEEP that we're going to set initially is going to be based on the BMI. If the patient is relatively thin with a BMI of less than 35, we'll use 10. If it's 35 to 50, we'll start with 12. And if the BMI is greater than 50, we'll do a PEEP of 15. Now, the reason you see these PEEPs increasing is as your abdominal girth increases, you need a certain level of PEEP to defeat the pressure of the abdomen before you truly start recruiting alveoli and improving oxygenation. And that's why you're seeing these PEEP levels increase with the patient's BMI. All right, now as I alluded to earlier, we're doing all these things, but we want to monitor on the ventilator to make sure that we don't have a plateau pressure, which is increasing greater than 30. Now, the reason for that is we want to limit the amount of barotrauma that we're giving the patient by giving them positive pressure ventilation. Now, there's different pressures that you will see on a ventilator monitor once you start them on mechanical ventilation. On our monitors, the top line of waveforms is going to be a pressure time curve, which is shown here on the right. And you end up having different pressures that you can see. You have a pressure here, you have a pressure here, and you have a pressure here. Now that bottom pressure, it doesn't say it here, but that's your PEEP. That's your baseline pressure when you're starting inhalation. This goes up to a maximum, which is your peak inspiratory pressure. Shortly afterwards, it drops to your plateau pressure. The reason for the difference in these inspiratory pressures is there's a certain resistance that you need to overcome to defeat both the airway and the lung. Once you defeat the airway, all you're left with is the resistance or the compliance of the lung. So the combination of the both is your peak inspiratory pressure. When you defeat the airway and you're only left with the lung, that's your plateau pressure. So your plateau pressure is giving you the best estimation of what the actual lung parenchyma is doing, how stiff it is, and how much potential trauma you're delivering. Now, What you're going to have to do to get nice waveforms like this and to be able to measure these variables is you're going to have to sedate the patient. It also helps us avoid overbreathing. So if you're setting a respiratory rate, let's say you're already at 35, you don't want them to be breathing over to 50. You also want to prevent double stacking where they're trying to take 2 breaths at the same time, because obviously that's going to create more injury as you are not delivering them the mode of ventilation that you want to. Now, how do you measure a plateau pressure? On the ventilator monitor, there will be an inspiratory hold button. You're going to press this button. It closes a valve in the inspiratory tubing after the tidal volume is delivered. And this will be a straight line that goes across the monitor. And on the right of the monitor, it will tell you what the plateau pressure is, and it'll be labeled as PPL. Now, these are some examples on the top of some pressure time waveforms. And as you can see, they're quite different. You can see on the left, there's a big difference between your peak pressure and your plateau pressure, whereas on the right, both seem very close to one another. Now, on the left, this is indicating that there's an airway problem. There's a big difference between your peak and your plateau pressure, which suggests that you have a high resistance in the airway. So once you defeat the airway, your pressure drops down to that plateau pressure. This is an airway issue. This is somebody who's in bronchospasm, who has a mucus plug, or potentially is biting down on their ET tube. Okay. So there is some troubleshooting that you can do based on these peak and plateau pressures. If the peak pressure is isolated alone and the plateau pressure is not elevated, this is, like I said, an airway problem, an ET problem, or a vent tubing problem. If both the peak and plateau are high, there is either a process going on at the alveolar level, which in the majority of our patients with COVID-19 is going to be ARDS. The lungs are filling with inflammatory fluid. But keep in mind that there also can be a process going on with the chest wall, whether that be increased abdominal girth from ascites, abdominal compartment syndrome, or a pneumothorax. Remember, these people are at risk for barotrauma and can develop pneumothoraces. So if you see the plateau and peak pressures increasing all of a sudden, you do want to keep in mind that there may be a pneumothorax. Now, the other reason for both of them being elevated is if the patient is doing spontaneous effort on top of what you're trying to deliver them, and they're generating vent asynchrony, or if they're coughing. All right. So there are some tools in our kit to try to troubleshoot if we're having trouble delivering them the mode of ventilation that we want. And the first and foremost thing that we can do is provide sedation. Now, whether this be by a drip of propofol, fentanyl, or benzodiazepines such as Versed. Now, some of this is going to change as this crisis intensifies. We will get low on certain medications, and we will have to decide on some of these drips based on what the availability is. In general, those are the 3 that I prefer. As time goes on, we may, shift to using some ketamine drips if we're running low on propofol, and we can use Precedex potentially to sedate patients. We try to avoid Ativan drips because it produces a lot of metabolic acidosis that we want to avoid. Now, another thing that we can try to do to make the patient more compliant with the ventilator is to adjust their flow rate. The flow rate is their inspiratory flow rate. So it's the amount of support that you're giving them in a period of time. All right, so the air is either going in fast or it's going in slow. If you put somebody on low tidal volume ventilation, it's unnatural for them. They may feel like they're not getting enough of a breath. Now, one way that we can try to fix that is to give them the flow very quickly. So that's increasing your flow rate. Now, what that's going to do is, if you see here on the right, there's something called the IE ratio. That's the time spent in inspiration to time spent in expiration. If you increase the flow rate, you are going to decrease this ratio. So you'll go from, let's say here it says 1 to 2, you'll go from somewhere from 1 to 3 to 1 to 4, because the time being spent in inspiration is decreasing as the flow rate increases. Now, there used to be a thought in ARDS that you want to have a higher I/E ratio to improve oxygenation. But this really doesn't have nearly the effect that increasing your FiO2 or your PEEP does. And it may make the patient more uncomfortable, which is something that we want to avoid. Now, let's say that we have our patient well sedated. We've tried to make changes with our flow rate, and the patient is still desynchronous and desaturating. This is the time where we're going to consider doing paralysis. We want to take over full control over the patient's breathing to give them the tidal volumes that they need in a safe manner. Now, our main paralytic agent that we use is Nimbex or Cisatracurium. The reason for that is this is our most studied paralytic in ARDS and has shown some benefit in some clinical trials. Now, again, depending on whether we get short, we may have to switch to other neuromuscular blocking agents, but this would be our first line agent. Okay, some other reasons that we might consider doing paralysis are if we have a patient initially who has a PF ratio of less than 50 in their first 48 hours of being mechanically ventilated. So this is an RCT from 2010, which showed a potential mortality benefit with giving people paralytics with Nimbex based on these criteria. Now, I will tell you within the last year, there was another RCT that was performed that did not show a mortality benefit. So there is some conflicting data at this point as to whether paralysis improves mortality. My guidance for this is going to be, if you need to do it to get control over the patient's breathing, do it. And if you are planning on doing prone ventilation, you're going to have to do this anyway. So that would be another threshold to start paralysis. All right, so just a summary of what we're doing so far. You decide the patient needs to be intubated. You're going to determine their height. You're going to calculate their predicted body weight, identify what that tidal volume goal is, which will be 6 cc's times that ideal body weight. You're going to deliver that. You're going to sedate the patient to avoid desynchrony. You can start at higher tidal volumes if you need to make the patient comfortable until they are fully sedated. But the goal is going to be to reach that target tidal volume, keeping in mind your goal plateau pressure within 4 hours of mechanical ventilation. And we're going to adjust our PEEP as needed to try to decrease our FiO2 and to try to increase our oxygenation. Okay, now this is a very heavy physiologic slide, but I want to start discussing prone ventilation. In short, prone ventilation is you take the patient from the supine position and you flip them 180 degrees. You put them on their stomach while they're on the ventilator. The reason that we are going to suggest doing this is there are randomized controlled data and Cochrane meta-analysis data which suggest that doing prone position ventilation in patients with severe ARDS, which in this case is going to be defined by a PF ratio less than 150, improves mortality. Now, I will also tell you it drastically improves their oxygenation. The reason that it improves their oxygenation is the majority of your lung is in the dorsum if you're lying supine. So that means a lot of your potentially recruitable lung is actually being compressed in the supine position. So if you just flip them onto their stomach, you actually will help recruit that lung. It also has been shown to be a more homogeneous perfusion of the lung, as you can see here. You have a lot more lung that is not participating in shunt type physiology if you just prone them. And the last thing that proning will do is it will take the weight of the heart off of the left lower lobe, which will potentially recruit even more lung. Now, here's our data from our largest randomized controlled trial looking at this. So they did prone position in folks with a PF ratio of less than 150 if they were within their first 12 to 24 hours of their diagnosis. And as you can see, there is a nice improvement in their case fatality rate. Now, the way that we prone is we do it in 16 hours sessions or more. So you decide that you're going to prone somebody, you flip them over and you leave them for 16 hours. At the end of that 16-hour session, you put them back in the supine position and you see how they're doing, and you will reassess the need on a daily basis of whether you want to consider proning. Now, important things that you have to keep in mind when you're proning the patient. The patient ideally should be paralyzed. This is so they aren't grabbing anything and nothing moves while they're in the supine position. It takes a team to prone a patient. You need people who are looking out for the ET tube, are looking for any central access to make sure nothing gets pulled or nothing gets disconnected. You also need a bunch of people in the room to make sure that you're flipping the patient in a safe manner. Now, we're working on protocols and nursing education to make sure that this is done safely. We're also working on an order within SEM to help with this process as well. Now, this is, it's going to be hard to read, but I just wanted to bring up the topic of self-proning in non-intubated patients. So you may have patients that are on 100% non-rebreather that aren't saturating where you want them to. What we're finding is if you have the patient prone themselves while they're on the non-rebreather, it does improve their oxygenation and potentially can be a save from having to put them either on high flow or having to put them on the ventilator itself. All right. Now, some other options for severe ARDS are inhaled nitric oxide, which will improve oxygenation, recruitment maneuvers, which are increasing the PEEP to very high numbers, APRV, which is a different mode of mechanical ventilation, or VV-ECMO. Now, if you're considering any of these options, you have to call us at this point. This is the point, and even if you're considering proning, it's better to call us and get us involved at this point to help you with these things. On the bottom right, this is, again, part of our hospital's protocol of how we're going to try to help with oxygenation. So we're going to do our PEEP titration. We're going to increase our sedation to the max that we need to. We're going to do paralysis. We're going to consider prone positioning. And then we can either give nitric oxide or epoprostenol. I would prefer nitric oxide as it has less hemodynamic variables and it requires RT going in less. And if none of these modalities are working, then we have to consider early consultation for VV-ECMO. All right, so at this time, I'm going to take questions. I'm going to leave this slide up for now because it also is giving you an idea of what we want to do in the general management of the critical care patients while I take questions. If you have a question, what you want to do is you want to wave. If you can see the wave bottom on the bottom, and that will tell me that you have a question and I'll be able to unmute you. All right, I see Nisha. Let me try to undo you here. Okay. Can you talk, Nisha?
Yeah, can you hear me?
I can hear you.
Great. Okay, two questions real quick. One is the inflammatory surge we're seeing day 5 to 10, where some people have a good early response and then they hit this supposed inflammatory surge, maybe IL-6 mediated. I'm wondering your thoughts about, number one, trying steroids there. I think the ICU has been doing it, and I have a couple of people on the floor on the COVID consult service that I think might benefit from that, and maybe, you know, thoughts on that and what dosing. Number two, people that are a D-dimer above a certain level, let's say 10,000, do you think it's worth fully anticoagulating these people?
I think both are great questions, and we're going to be discussing both of them in detail in the next half hour.
Great, thanks.
No problem. Okay, anybody else have a question?
Hey, Jared.
Yep.
What's the data for VV-ECMO? Is it like what have you seen come out from it?
It's very poor. So overall survival for patients with COVID-19 requiring ECMO are very poor. But obviously, I think this is something that we need to, you know, occasionally consider in the right person. You know, if you have a young patient without comorbidities, you know, that might be the person that you want to try on VV-ECMO. But it's going to be a very highly select population.
Okay. And bivent, we're not going to go directly to bivent or BiV?
I wouldn't suggest going directly to bivent. The reason I wouldn't suggest it directly is There's no consistent data demonstrating a mortality benefit for bivent in patients with ARDS, where there is for low tidal volume ventilation on volume control. The way that I view APRV is it can be used as a rescue modality if you have patients who are hypoxic despite these things that we have been talking about.
Okay. And I think on the floors, at least, we've been trying to keep everyone like very dry. And clinically, I've had some good success with when my patients are deteriorating on the floors, giving them a little Lasix and buying myself a little time. Are you finding that's true for ICU as well?
So you're preaching to the choir, actually. Anybody who rounded with me in the last week knows that I drive people's sodiums up to sky-high levels. But yes, so there's no data suggesting that aggressive diuresis or conservative volume strategies improve mortality, but it definitely improves oxygenation and it definitely decreases the time to extubation.
Thanks, Jared.
Okay, I see Aisha has a question. I'm just going to unmute her.
Hey,
Yep.
Jared, I was just trying to tell you there's a lot of people asking questions on the group chat.
Yes, I am trying to
Okay.
respond at the same time that I'm talking. It's good since, you know, my attention isn't that great anyway. But yeah, so I see a question here about running low on drips. Are pushes as effective? They are as effective, but keep in mind giving pushes are going to require healthcare workers to go into the rooms more often. So in general, we've been trying to do everything as drips to try to decrease the amount of time that providers need to go into the room. Same thing, same idea with Foley catheters, rectal tubes if they're having diarrhea and things like that. See, another question here is from that there are some patients that have a very poor compliance and are dying from hypercarbic respiratory failure. Is A-lung an option to consider for these people? They are providing compassionate use for the A-lung, so it's something that we can keep in mind. If you're having very poor compliance with ARDS, generally you're going to have very poor oxygenation, and while MVV ECMO may be the better modality, but again, this is something that we would talk about on a case-by-case basis. Okay, is there a plan to externalize ventilators, and if so, what is the time frame? We're not going to externalize the ventilators, but we're trying to do in select rooms is have the monitors outside the room. So engineering is trying to drill a hole in certain appropriate rooms where we can do that. Thoughts on splitting ventilators? It may need to get done eventually. We're not at that point yet. I think the people that we should consider splitting ventilators are going to be those who don't need very high levels of support and have very similar ventilation needs. Let's say you have two patients with ARDS who have similar tidal volumes. Those are the people that I'm going to want to connect to the same vent. Okay. What has been our outcome of COVID and ventilated patients in the ICU? I can tell you anecdotally, it hasn't been great, but it's not great for ARDS in general. Nationwide, it seems if people are put on the ventilator for COVID, in general, there's about a 20% success rate. But you know, as we collect more data, hopefully that becomes better. Okay, at this point, I think in the interest of time, we're gonna move on to our second lecture. So this is going to be given by Kathy, one of our Pulm Crit Care Fellows, and I'm going to chime in as well at certain points. This is going to be more, This is going to be designed to be more tailored towards controversial topics in the management of these patients. Let me just pull this up. Okay. So at this point, I'm going to, don't do that. I'm going to unmute Kathy and she will start. Just give me 1 second. Okay, looks like Kathy is unmuted. You're ready to go.
Okay, can you hear me?
Yep.
Okay. All right. So, do you want to just play the slide or?
Yep.
Okay. Hi everyone. So I'm gonna be talking about a couple controversial topics, like Jared had mentioned. You can move on to the next slide. Should I just tell you when to move?
Yeah.
So obviously, I understand that it's probably hard to pay attention to everything we're saying right now, especially because I'm not just talking to a Palm Crit department. And, according to this pie chart that I found on Google, you probably will only retain 2% of what I actually say. So at the end of each topic, I'm going to include a slide that will be a conclusion slide that Jared and I will weigh in on. So we're going to talk about steroids, the H-score, Tocilizumab, anticoagulation, and convalescent plasma. Next slide. Okay, so before I actually start, before I go into the topics, I wanted to take a step back from all of this COVID business and to just reflect back on this year that is March, because it's been a crazy one. And as for full disclosure, these following slides are not meant to offend anyone, but they are intended to provide comedic relief during these times. Next slide. Okay, so March actually started off last month pretty productively. To the left, you can see our second years actually pretending to study. And then on the right, you're seeing that this Dr. Borakov gave a coronavirus talk. We were getting educated about all this business that was going on. Next slide. Social distancing eventually took effect on us. I think the second week we had celebrated our chief Ibrahim's birthday. We gifted him Lysol as a joke. And for our new conferences, we were only allowing 15 people in, and we were all social distancing. Next slide. We joked about, toilet paper. The top is my hall, the bottom is Ibrahim's hall. There were memes on the internet all about toilet paper and toilets and London still falling asleep in lectures. Next slide. By the end of the second or third week, we started our surge schedule. Actually, no, we started our surge schedule last week. So a lot of things have changed in the Palm Crit department. We've pretty much been in high spirits. Now there's 2 fellows on during the day when there used to only be 1 in the unit. And we have 2 fellows back in the unit at night as well. Oh, we never had 2 fellows on at night, actually. So this is also new for us. Next slide. It's been a mentally draining week with the amount of sick people that we've been seeing. And you can see our chief has been having really crazy mood swings. He's either going crazy or he's just making really sad puppy dog eyes. And lastly, our attendings, they have really let go. Dr. Hussein, pictured at the top slide, pulled a April Fool's joke on us, saying she was actually leaving us to help her colleagues at Columbia. I think we all cried. And Dr. Sunaram, pictured at the bottom with his colleagues, Dr. Scardella and Dr. Barham, flew out to Florida, I believe, to actually party in Florida in a club. So, okay. Yeah, but in all seriousness, it's been a rough month, but obviously very grateful to be where I am and to work with the co-fellows that I have. So moving on to steroids, the first topic I'm going to be talking about. SCCM actually recommends, you can see where it's circled. Jared, hit the slide again. That they do want to consider a short course of systemic steroids for moderate to severe ARDS. Next slide. This is the SCCM recommendation. In patients without ARDS, they suggest against the use of steroids, but in patients with ARDS, they suggest using systemic steroids over not using systemic steroids. Next slide. So this paper from China, I believe all the papers that I'm speaking about are from China, looked at starting early low-dose steroids in patients with severe pneumonia, and they used a dose of 1 to 2 mg per kg per day for 5 to 7 days of Solu-Medrol, and this was seen to be associated with shorter duration of supplemental oxygen use and improved radiographic findings. They had an N of 26, and they used a PF ratio of less than or equal to 300. And these slides, you can see the images of CAT scans on day 1, 7, and 14 after hospitalization with severe pneumonia, and the left with steroid treatment with significant improvement, on the right without steroid treatment. The next slide is a paper in JAMA. The study showed an association between steroid use and lower mortality in patients with COVID-19. So when they looked at patients with ARDS who were treated with steroids, there was a decreased risk of death. Next slide. You can see where I highlighted in red of the patients. So this is a big slide, but basically patients with ARDS, a total of 200 patients were in this study, 62 of whom got steroids. Of those who were in ARDS who got steroids, 23 out of 50 died, and those with ARDS who didn't, and 21 out of 34 didn't die. Next slide. The Kaplan-Meier curve is more representative of what you see with steroids in patients who developed ARDS. The World Health Organization also came out with their guidelines, but they recommended against giving steroids because when they looked at the past papers on MERS, especially MERS, they did not find any effect. And the concern with steroids is, you know, you're at increased risk for secondary infections, you have impaired viral clearance, prolonged viral shedding, and there's more adverse effects with survivors like diabetes, psychosis, and avascular necrosis. But at our conclusions, you know, as I graduate in 3 months conclusions, I will give the 1 to 2 mg per kg per day for 5 to 7 days in intubated patients with ARDS in the setting of high inflammatory markers, as long as there are no positive bacterial cultures and a normal procalcitonin.
All right, and for me, who thinks about this all the time, I agree with this dosage of steroids in COVID-19 patients with ARDS in the setting of high inflammatory markers. I do caution that if they are going to go into ARDS from some type of cytokine release syndrome, my feeling is that that's going to happen probably a week to 10 days after the onset of symptoms. During the beginning of that time, majority of what's going on is going to be due to viral replication. And I do think that giving steroids too early may help promote the viral replication by further decreasing the T cell cytotoxic mediated immunity. But I think later on in the course, if they have ARDS, this is reasonable to do, especially if they do not have an improvement in their inflammatory markers once you start low tidal volume ventilation and proning as needed.
Okay, so the second topic is the H score and Tocilizumab. So the H score is something that we have used for diagnosing reactive hemophagocytic syndrome, what we know as HLH, and it's basically this overwhelming inflammatory immune response. What we've been seeing people have been doing is using the H score for COVID-19 patients because these severe COVID-19 pneumonias have actually been leading to this cytokine activation syndrome and secondary HLH. And on the right, you can see this chart where they looked at risk factors of COVID patients associated with ARDS and death. In what I highlighted in red, you can see that they found that these COVID-19 patients with ARDS had very high neutrophil counts. And it's been shown that neutrophil activation likely is a contributor of cytokine storm and ARDS, along with another paper that stated high CRPs correlate with disease severity and prognosis of these patients as well. So in looking at the H score, next slide. This is, on the right is the H score looking at temperature, organomegaly, number of cytopenia lines, triglycerides, fibrinogen, ferritin, AST, bone marrow aspirate, which we won't do on these patients, and known immunosuppression. A score of greater than 169 is 93% sensitive, 86% specific for HLH. And you can actually trend these inflammatory markers in H scores to identify patients who can benefit from immunosuppression. And this includes things like steroids, IVIG, Tocilizumab especially. And the next slide will show that the SCCM does not actually recommend Tocilizumab for critically ill patients because in their one study that was done in China of these patients who were treated with Toci, 21 hypoxemic patients, it was only one study, and it was a case report of 21 patients that did actually show improvements in CRP, FiO2, saturation, and temperature, but it was not a peer-reviewed article, which is why they're not recommending it.
¿Puedes hablar con Evelina? ¿Sí o no? No. Por eso. No, dice que no.
Okay, anyways, so in my conclusions, for H score and Tocilizumab, of course, obviously more data is more power. So I will utilize the H score, and I guess in clinical trials, if there are clinical trials for Toci, then I would eventually, or maybe use Toci. Okay.
Sorry, I was just muting people. So my conclusion here about the H score and Tocilizumab is, I think if they are hitting this threshold score for HLH, I'm not sure that this really can be reversed at this point. I'm also not sure what medications to give or when. So, you know, in the first couple of weeks of treating these folks, we've been trying to use Tocilizumab to decrease and treat the cytokine release syndrome and prevent the patients from going into full-blown HLH. But what I'm finding anecdotally is we give them the dose of Tocilizumab, their CRP goes down, but they still progress into HLH, although their oxygenation does get better. So I think there's more going on to this than just, the B-cell mediated IL-6 pathway. And I think when this is all said and done, Tocilizumab is not going to be the answer here, unfortunately.
Hey, hello?
We can hear you.
Oh, hey, what happened?
Should be going. Go.
Oh, sorry, I don't know what happened. Okay, so I guess this paper was looking at abnormal coagulation parameters associated with poor prognosis in patients with COVID pneumonia. And 100 out of 183 coagulated patients, they looked at the patients with significantly high D-dimers and fibrinogen degradation products, longer PTTs, actually had a significantly decreased survival rate than those who did not. And the next graph is just another pictorial graph from the same paper. As you can see, the green represents the non-survivors. They had a much more variable range of coagulation parameters than the survivors did. And then the next slide is a paper from Lancet that looked at clinical course and risk factors for mortality of adult patients with COVID. And I just grouped all of the coagulation parameters. Basically, these non-survivors had higher white blood cell counts, lower lymphocyte counts, higher LDH, D-dimers, serum ferritins, and the graph on the right just is sort of a pictorial presentation of the survivors and non-survivors. The non-survivors in red with more elevated D-dimers and IL-6 and CRP and everything else. So this paper was the only paper that looked at anticoagulation treatment in patients with COVID-19. They treated 99 patients with low molecular weight heparin or Hep sub Q for 7 days, heparin for 7 days, not Hep sub Q. And they found no difference in 28-day mortality found between heparin users and non-users. And the 28-day mortality for heparin users were lower than those in the non-users. They used a 6 score, which basically comprises of platelet count, PTINR, and the SOFA score. And they use it for patients with D-dimers of greater than 6-fold the upper limit of normal. I don't know if Jared mentioned it earlier, but we're seeing D-dimers of over 120,000, and usually the upper limit of normal for Robert Wood is 500. So again, another graph here of patients who did benefit from the anticoagulation were those with a 6 score of greater than 4 and a D-dimer of greater than 6 times the upper limit of normal. Next slide is just sort of like a molecular slide, a hypothetical pathogenesis of COVID-19. So the dark, the red line is what we're looking at with viral replication. And then the dark blue inflammatory markers, this is what we're seeing right now. If you click again on the slide, Jared, you'll see what happens when we give these patients therapeutic Lovenox is what we're expecting to see. The dark blue dots is the inflammatory markers would go down. This is what we're sort of hypothesizing what is happening with anticoagulation. So my conclusions for anticoagulation would be for a D-dimer of greater than 4 to 6 times the upper limit of normal. So it's 500 times 4 to 6. Start therapeutic heparin for at least 3 to 5 days.
Yeah, so I agree with that. I'd also add that there's some emerging evidence most recently published in the American Journal of Respiratory and Critical Care Medicine that the dead space ventilation in these people with ARDS is out of proportion than what you would expect by just giving them low tidal volume ventilation, which to me suggests that there's a good extent of microthrombi being formed in the pulmonary capillaries. And this is probably what's contributing to that increased dead space. And I think, this degree of thrombosis is making inflammation worse as well. I'm starting to become a very big proponent of anticoagulation in these people. And I think it's actually time for us to start a randomized clinical trial now.
Okay, so the last topic that I'm going to speak about, I guess I'll take the last 5 minutes, is convalescent plasma, which you've probably all been getting emails about. We're actually doing it at Robert Wood too. I think we're starting to take blood from people who have been tested positive before. So the SCCM actually suggests against using they do not recommend using convalescent plasma. In the past, convalescent plasma has been used to treat SARS, H1N1, H5N1, but the data is very limited, and the data has been effective in treating SARS, but there's a lot of unknowns. There were no good results for MERS. It didn't work for Ebola. It didn't work for seasonal influenza. This meta-analysis that I have on the right here from 2015 looked at using convalescent plasma in SARS, coronavirus, and severe influenza with an actual benefit. Next slide shows you the forest plot. There were 8 studies that they looked at, and all of them favored giving convalescent plasma or convalescent serum for either SARS, coronavirus, or severe influenza, not seasonal. This paper was the only paper that came out recently, looked at 5 patients in China who were treated with this convalescent plasma, and it was of benefit. The plasma they used had SARS-specific IgG binding titers of greater than 1 to 1,000, and neutralization titers of greater than 40. Basically just means that the titers took, I guess with neutralization, it just means that what you want to neutralize the antibody to make it actually effective. And the outcomes of this, everything in these 5 patients improved, including body temperature, SOFA scores, PF ratios, viral loads, ARDS resolved, and these 3 patients were weaned from the mechanical vent within 2 weeks of treatment, and they followed these patients for, I think, 2 months, and they all benefited from this. So this chart were the 5 patients that were treated. Just to point out that none of them were smokers. 4 out of 5 of them had no pre-existing medical conditions, and all 5 of them had received antivirals and steroids, and the plasma was administered between 10 and 22 days after admission. And this graph sort of shows pictorially what happened to the SOFA scores, the body temperatures, and the PF ratios. So in conclusion, give me your plasma.
Yeah, like, if it worked for flu, it'll work for you.
Thank you.
All right, so at this time, we'll take some questions. I know this is a Department of Medicine meeting, which is gonna start very quickly. So we'll take a couple of questions, and then we can, take offline questions afterwards. Okay, so I'm gonna take that as no questions at this time. Thank you everybody for listening. And oh, it looks like there was there's a couple on the chat. So let's see, we have, please comment on hydroxychloroquine use in the ICU, on patients not on remdesivir. We've been giving hydroxychloroquine to everybody. I don't know if it's helping. I don't know if it's hurting in the ICU because everybody's on it. It's not controlled for placebo. But I think
I just want to say we're actually doing a study for that. We just started enrolling. We enrolled our first patient last week, but we're going to be enrolling. So there'll be 3 arms: hydroxychloroquine plus azithro versus just hydroxychloroquine versus no hydroxychloroquine for 6 days and then hydroxychloroquine. So yeah, please try not to just put them on randomly right now. I did send out that email to the fellows, the residents and stuff, so they are aware, like when they write their initial orders, and then we will be screening them and then randomizing them.
Yeah, and I'd also say we do have remdesivir trials going for patients with moderate and severe disease. So that's another option for us as well. Okay, so I think one other thing that I want to talk about is, for the patients who are in the ICU, we've been having multidisciplinary conversations on everybody between us and infectious disease every day at 1 p.m. I think it would be very useful to add a person from hematology and add a person from cardiology to be on the calls, so we can start making some of these decisions about anticoagulation and potentially about advanced shock support for patients who develop cardiogenic shock, whether it be from myocarditis or other etiologies. So if you guys have any other questions, you can obviously email me independently and I'll get back to you as soon as I can. But I think at this point, we're going to move on to the greater Department of Medicine meeting. I thank you guys for listening. And if there's any ways we can help further, please let us know.
Just so everyone knows, the meeting has been pushed to 1:15.
Okay, then I have some time for a couple more minutes. I see Libby had one.
Yeah, hey, can you hear me?
Yes, I can.
Hey, this is Libby Schroeder. I'm one of the ACS attendings. So we actually, our ACS group, first of all, thanks for extending the invitation to us. I don't know who else from our division is on the meeting, but we really appreciate it. You know, we were waiting to open our surge unit in New Brunswick, but we've been taking care of a lot of these patients over at Somerset. And the coagulopathy part of things has been very intriguing to us. And we actually, when we met as a division yesterday, we're talking about it. One of the things, just so you know, and I'm happy to communicate with whoever is appropriate, we've reached out to the lab to see if we can run some ROTEMs on some of these patients to try and look at their actual coagulation factors. One of the things we noticed in that anticoagulation study that was sent out is, like, the D dimers are obviously off the charts different, but like the PTs and things aren't actually that difference between the groups. I think it's like 1.5 difference, but I think it was like 12.5 and 14 or something like that. So anyway, we were interested in being able to run some road temps on these people and actually look at, get a bit more information about their coagulation profiles. So if we get clearance, the lab's getting back to us about whether that's possible, and then maybe we could try to identify some of the patients that you guys have about who that would be appropriate to do.
Yeah, I agree with you. And anecdotally, I've been collecting data as part of a multi-center trial, multi-center observational study. And I agree, we're not seeing this elevated PT and PTT really until the day they die. And it seems like a lot of the people, if they go into HLH, look like they're developing DIC at that point too. And that's when our fibrinogens, which go from unmeasurable, drop, and our platelets drop as well. So I agree with you. I think that might be very useful. Okay. I saw another question as I'm going through these about rationing of care in a way. Is everybody going to be put on ventilators and things like that? My answer to that is we are trying to make this provider independent, and there will be a criteria that's generated by the ethics committee, and we will basically be going by those criteria to be making those types of decisions. Okay. I'm going to unmute Ehai. I hope I pronounced that.
Hi, oh, that's okay. This is Ehai from cardiology. Thanks for that talk. I hope you guys are okay sending out the slides. It's a lot of information to take in. 2 questions. One is, obviously by the time everybody's so sick that they're on, sort of Plaquenil or one of its sort of cousins, or an azithromycin, people are pretty sick. I was just wondering, since some of those agents are associated with cardiomyopathies, is there any plans to kind of follow things like QT prolongation and other potential sequelae while people are sort of in the ICU? So that's my first question.
Yeah, so we've been monitoring the QTs on a daily basis for people who are on hydroxychloroquine, and especially people who are on hydroxychloroquine with azithromycin. Although I'll tell you, over the past week or so, we've started to drop azithromycin from our algorithm, although now obviously it's going to be part of this trial, to look to see what added benefit there really is with azithromycin to hydroxychloroquine. In terms of developing cardiomyopathies and things like that in the unit, we've been measuring troponins and BNP, CPKs on a daily basis. I personally also look at mixed venous saturations on a daily basis because these people have very unpredictable courses, and there's some folks that start developing myocarditis that, you know, will have a short peak and they resolve, but there's some people that will go into fulminant myocarditis within, you know, a matter of hours. So this is really why, you know, including somebody on this cardiology multidisciplinary call would definitely help us going forward.
Great. And then if I could ask one more question. While the sort of ethics committee is deciding what exactly to do, you know, I've spoken with some of your colleagues just randomly about this, but some of us are going to come across this obviously. What have you all been doing in situations where people are clearly sort of end game, and you know, if they were to code, you know, the potential exposure of doing CPR on those people? What are the conversations you're having with the family? Are you essentially telling the family that the patient's DNR? Like, how are those things kind of going, and are you navigating that?
At this point, we've been navigating it on a case-by-case basis. I know that's a very political answer, but I can tell you it's very difficult in general to have these conversations, but it's even more difficult now because they're not allowed to visit. So all these conversations we're having with them are on the phone, and they can't even really see the decompensating patients. So it's difficult. So far, most of the people that have entered a situation where I see that basically doing CPR and things like that would be futile, I've stated that to the families and have made patients DNR in those situations, including, unfortunately, a 40-year-old with no comorbidities who went into Florida HLH. So you can't push them necessarily for those things, but I think if you're very upfront with the idea of CPR being futile, in general, people seem to understand that. Now, I know that there have been states of emergency which have been declared in the state of New Jersey. So some of these autonomy decisions may be changing over the next few hours, you know, depending on how bad the pandemic comes and how, you know, really overrun the hospital system becomes.
Thank you.
I'm going to unmute pulmonary critical care.
It's Andrea. May I share a slide with you?
Sure. I don't know if I know how to do it.
You need to disable the participant sharing, screen sharing.
Okay, let's see.
Because we're talking about the microthrombosis, and there is a beautiful slide that I would love to send to everybody, including a proposed pathophysiology. It's probably at the bottom somewhere for you.
Well, let's do this. I'm going to make you host for a session.
Oh, you did it. You did it. I got it.
Yeah, okay.
Oh, no, it didn't. Never mind.
Hold on. It should go through now.
Okay, got it.
Now you should be able to share your screen.
I will be happy to. So here you go. This is what I saw this morning on what's going on as far as proposed pathophysiology of how the microthrombus works. And you know, I'm not a hematologist, but it's very interesting. There's a whole chat about this going on, and what they're suggesting is that the microvascular thrombosis leads to all of these problems. And one of the things they are proposing is to treat the endothelial dysfunction to begin with. And early proposed interaction would be to use Lovenox or aspirin. And then later on,
this is great. Andrea, if you could send me this slide, I'll disseminate it to as many people as possible. We just
okay.
Sounds like the other meeting has started. So
okay, here you go. I need to give you back your controls.
All right, thanks, Andrea.